Many people will tell you that what I do is completely silly. Spine fusion's bad because a lot of people don't get better, and even if they do get better, they always burn out another disc. And we know that the chance of the fusion patient getting in trouble again is about 3% per year of life. Once we defined that, we said, if spine fusion bad, motion preservation is going to be good, and hence the 4 different alternatives I mentioned before on motion preservation in spine care. These are only some concrete examples. IDET is intradiscal electrothermia. It was an attempt to repair the disc's internal structure with a percutaneously navigated electrothermal catheter. Charité and ProDisc are disc replacements. There are interspinous spacers out there to jack your spine open. There are ligamentoplasties of a number of sorts. There's lots of MIS work that proposes to avoid destabilization, so to avoid the need for concomitant fusions to start with. When you look at them, the evolution of the literature on all these technologies is exactly the same. The thing comes out of the blocks 95% effective with virtually no complications anywhere. It takes about 4 years for literature to start coming out that's independent of the people developing the technology or the product, and inevitably the technology turns out to be less than 50% effective with lots and lots and lots of complications, and it dies in the marketplace. I've seen 10 or 15 generations of that already in my practice years. Charité is a classical example of that. Fda Study releases it into the world marketplace in 2004. It is a big business. These disc replacements sell for $11,000 a unit. You can put 3 or 4 of them into one patient if you want to. The company is still regularly pumping 50 surgeons a weekend through its training center in Cincinnati. The FDA study is so bad that Blue Cross, Medicare, and now Kaiser Permanente have all published their criticisms of the study and refused to pay for the implants. When you look at the FDA study that told us the Charité prosthesis was so good, it was historically controlled with a fusion implant called the BAK. The BAK study at its time was quite famous in spinology. It's a PRCT of over 1,000 cases, unprecedented in 1996. When you read the paper, as opposed to reading the abstract, it's an analysis of about 200 patients. 80% of the patients enrolled into the study never got looked at or analyzed. The study is meaningless. If the controls are meaningless, then the new study is meaningless. We don't know anything about lumbar disc replacement to talk about. Competitor into the marketplace, ProDisc from Synthase was pushed aggressively into the marketplace to compete the same way Dr. Miller's joint replacements were pushed out to compete with Dupuis. The ProDisc study is so flawed at a fundamental structural level that it's in front of the U.S. Department of Justice. Every single surgeon participating in this prospective, randomized, independent, yada-da-yada-da study of a new surgical technology was basically on the payroll of the company. X-stop is an interspinous spacer. The FDA study, finally we're getting a little bit more honest with our data, is relatively recent. It failed at FDA, and they wouldn't release it to the marketplace. So what did they do? Did they do another study? Did they do an independent study? No. They took the database, did a post hoc analysis, kind of like the methylprednisolone people. I don't know if they got together on a weekend or what. Found a subgroup where they could show a benefit, took it back to the FDA, and FDA, our leaders, approved it. And we're now selling 50,000 units a year into the U.S. marketplace with no data to show a benefit to the patient at all. Infuse is similarly in front of the U.S. Department of Justice for similar considerations. And don't believe me, and don't believe the medical literature, but if you look it up in the New York Times or the Globe and Mail archives, you'll find very public critical articles on this and other issues in spinology. It's a really challenging field to work in. Doing the spiny work is easy. Understanding literature is what drives me nuts. Infuse, that bone morphogenic protein, is a very powerful local biohormone. But it can cause a big inflammatory reaction. And when it was proposed to be studied for use in the neck, it was found to be unsafe because it can cause a very massive swelling of the neck. Comes on a slightly delayed basis. Takes about 4 days after operation to happen. But people swell up so much they blocked off their airways and just about choked to death. So the product brochure says, do not use it in the neck. My literature is actively discussing what's the right dose to use in the neck, even if we use it off-label. Just nuts. Minimally invasive spine technology is another very, very sexy thing in my marketplace. If you fly on Air Canada right now and read the On-Board magazine, there's a full-page ad of a beautiful young lady with a Band-Aid on her low back who allegedly just had a minimally invasive spine operation. It's a really nice picture. I looked at it for a long time. Anyway, MIS has been out there for 15 years, and independent quality type 1 data from people who do not have a vested interest in the technology has just been published. It's not even published in the spine literature. It's in JAMA, August Journal of the American Medical Association. It shows no benefit. It's stunning. So why is it so popular? It's a huge marketing tool for the business of spine surgery, both for the surgeons and the companies. And just, even in Canada, where dollars are very, very small compared to the whole rest of the world because of what socialized medicine has done to us all. For a long time, every time we did a minimally invasive case at the Hamilton General, we were paying $800 a case in loaner fees to the companies to get the technology. 2 years ago, we finally bought the implant set, and we spent $35,000 out of a hospital budget that's perpetually broke for something that shows no benefit to the patient whatsoever. It's just really tough to understand what the literature is telling you. Basic discectomy, like my 3 o'clock case. When we look at the literature going back to 1934, when disc hernia was first recognized for what it is, there are only 5 studies that have any reasonable quality at all. They're all flawed by crossover rates in the 30 to 40% range, and really the concrete literature on discectomy doesn't tell us about any benefit at all. The most old-fashioned basic surgical thing to do in spinology isn't supported in the literature. So why do you need a course like this? You need to know how to read and interpret that literature. I'm blessed. I practice in a collegial environment with people like Mo and Emil and Brad around. So I tend to think in that direction, and I've avoided a lot of tragedies for my patients by being that kind of self-aware. Many, many surgeons haven't. I see patients compromised by bad technology a lot. We want you to be better than we were. We want you to be better than the NIH academic study boards and the editors at Spine and New England Journal. I want you to be cautious in interpreting the literature. From the beginning of the paper to the end of the paper. I want you to look at the study question and say, all right, what are they asking? I want you to look at the outcome tools and say, okay, did they really use the right outcome tool? I want you to look at it and say, okay, who did the study? Are these people who are going to be able to study the technology, or are these people selling the disc? I want you to look at who funded the study. Is this independent data, or is this something that the company bought and paid for, that the company controls the data release about? I want you to be able to read that paper in the Canadian Journal of Surgery and make up your own mind as to whether you think people really, really need to be treated for their osteoporosis to prevent death, which I'm not so sure about, or whether we should treat our osteoporosis to prevent fractures, which I think I would agree with. At any rate, there you go. There are really, really big, important, fundamental questions in study design and execution, and it's not just statistical significance or what's the minimum clinically important difference. We hurt people when we apply these studies done inappropriately, make the future of medicine better than it isn't right now. Thank you.